So good morning, dear students. We are glad to present you the lecture from the neurosurgery that is called Traumatic Brain Injury and the Spinal Trauma. My name is Dr. Kulak Andrei, and today I will present the lecture for you. First, we start from some lecture overview. I suppose that is very important to reinvent some clinical neuroanatomy that usually helps us in better understanding of some pathological processing. Next, we will talk about some basic neuroimaging. What types of neuroimaging do we have and when do we use them? Next, we will talk about the brain concussion, brain contusion, different types of hemorrhages, and next we will finish with the spinal trauma. As you know, our nervous system consists of the central nervous system that include the brain and the spinal cord, and the peripheral nervous system that include cranial nerve, nerve roots, spinal nerve, and it terminates with the peripheral nerves. Also, it is very important to know that our nervous system is working throughout the reflex. If the information is upcoming to the nervous system, it starts with the efferent nerve root, then the information comes to the spinal cord, to the special segment of the spinal cord, where we have some interneuron. The sensory information is proceeding in this area, and the motor response is going throughout the efferent neuron and goes to the muscle. So here we have the overview of the brain. As you know, the brain consists of two cerebral hemispheres. So the hemispheres are localized upper to the cerebellum, and under the cerebellum we have the brainstem. On the cross section of this hemisphere, we can see some other parts of the nervous system. Two hemispheres are connected throughout the corpus callosum. Here you can observe the cross section of the cerebellum and the brainstem. It is also very important to know the covering of the brain. The most outer part of the skull is the skin that is tightly connected with the bone. Here we have the aponeurosis that is not represented here, but just under the skull, under the bone tissue, we have the Dura Mater. It's the tight part of the tight part that protects the brain from some damaging. Under the Dura Mater, we have the Arachnoid Mater that is connected with the Pia Mater throughout these trabecular structures, and then we have the brain itself. So the brain and the spinal cord are invested by three meningeal layers: the Dura Mater, the Arachnoid Mater, and the Pia Mater. So also it is important to know that we have two sheets of the Dura Mater: the falx cerebri, that is dividing two hemispheres, one from each other, and we have the tentorium cerebelli that covers the cerebellum and divides the intracranial space to subtentorium and epitentorium place. The cranial Dura Mater contains veins, sinuses that act as channels for the venous drainage of the brain. So the blood flow is supplied to the brain throughout the internal carotid artery and the vertebral arteries that we will talk about later. And the spinal cord is supplied with the blood vessels that arise from the vertebral arteries. It is also very important. So here we have the anatomical structure of the circum of Valysium. So this circle of Valysium is called because we have the connection between the arteries that can that can provide some additional blood flow if some of the artery is, for example, obstructed or some other problem happens to it. So we have two pools. We have the vertebral basilar pool and we have the internal carotid artery pool. So the vertebral basilar pool provides the blood supply to the brainstem, to the pons, midbrain, and also to the cerebellum and the occipital lobe. This is the main areas that are supplied with the posterior pool. If you are talking about the internal carotid artery, the internal carotid artery provides the blood supply to the whole hemisphere, as you can see here and here. So here we have two vertebral arteries that are traveling throughout the special foramen in the cervical vertebrae. Then they connect. They are connecting and forming the basilar artery that is localized on the anterior part of the brainstem. From this basilar artery, we have some small arteries that are supplying the different parts of the brainstem. And then we have two posterior arteries. Posterior cerebral artery that are providing the blood supply to the occipital lobe. If you are talking about the internal carotid artery, so here we have the internal carotid artery pool. So it terminates in two main blood vessels, the middle cerebral artery and the anterior cerebral artery. So why these blood support structures are called the circle of Valysium? Because of the communicating artery. Two anterior cerebral artery are connected by each other throughout the anterior communicating artery, and two middle cerebral artery are connected throughout two posterior communicable artery with the posterior cerebral artery. And as you can see here, yeah, it forms the circle, and it's provide this anastomosis. Yeah, this type of structure can help us to provide some blood supplies in case of some ischemia. Here you can observe how the blood vessels looks like in different investigations. So here we have the internal carotid artery that terminates in middle cerebral artery in the anterior cerebral artery. On the angiographic, this is the type of investigation when we provide some contrast inside of the artery, and then we observe if there are some block. Like here, you can see that the middle cerebral artery have only one branch, and the anterior cerebral artery is also a little bit obstructed. This type, so here we have the MRI angiography. So this is not, we do not provide any intravenous injection. Yeah, it's just the MRI that represent this type of these blood vessels. And also we have two vertebral artery, the basilar artery, two posterior cerebral artery. So here we can observe the Valysium circle. As you can see from here, the middle cerebral artery. So this is the lateral view of the brain. As you can see, it supplies a huge amount of the lateral part of the hemisphere. The anterior cerebral artery provides the blood supply to the to the middle part, yeah, to the inner part of the hemisphere. It is also important to know about the cerebrospinal fluid circulation. First of all, cerebrospinal fluid is the product of the supple filtration of the blood. This is not some special type of aqua. Yeah, it's just the super filtrated blood. So the cerebrospinal fluid is producing inside of the ventricles. As you know, we have 4 ventricles in our brain. Yet 2 lateral ventricles, the 3rd ventricle, and the 4th ventricle. And this is the general idea of the CSF circulation inside our brain. Here, each ventricle contains the choroid plexus. This is special terminals of the artery that produces or secretes the cerebrospinal fluid. Cerebrospinal fluid, so the direction of cerebrospinal fluid is we have already talked about. It is important to know that normally we have about 150 milliliters of cerebrospinal fluid, and this volume of the CSF is reproducing throughout the day. So many times, maybe from 5 to 10 times, the amount of cerebrospinal fluid is removed and produced one more time. So here we have the neuroimaging, and neuroimaging is one of the most important investigation in neurosurgery. There are 2 main types here that are widely represented in any hospital. We have the CT scan and we have the MRI. So on these both images, we can observe the brain itself. It's a normal brain. Yeah, nothing special happens here. But what is the difference between the CT scan and the MRI? In what case should we use each of these investigations? So first of all, we need to know some basic anatomy here to know what is going on inside of this investigation. So here we have the frontal lobe, yeah, the brainstem, the temporal lobe, occipital lobe. This is the sagittal view of the brain. And here we have the axial view of the brain. It's the most middle section because the brainstem is crossed in the middle part. Here we have the cerebellum. But what should we observe from these 2 images? First of all, the much more higher quality of image on the MRI. As you can see, we can distinguish any gyrus. We can precisely see any structure of the nervous system. Yeah, the hypophysis, the cerebellum. We can see every detail on this investigation. On the other hand, the CT scan is much more rude, much more lower quality of the image. But we should know that the CT scan is performing much more quicker than the MRI. If we are talking about the brain, the average time that needs for performing the CT scan is nearly from 5 to 10 minutes. And so we need like 45 minutes to perform the MRI of the brain. So let's go to this slide. And so we can see the different sides of the CT scan and the MRI. So first of all, we need to know that the CT scan it's the same as X-ray. Yeah, it's the multiple X-ray that is taken at different angles to produce cross-sectional images. On the other hand, the MRI is the magnetic field. It produces the magnetic field, and the computer is analyzing the concentration of the hydrogen atoms in different tissues and provide the high quality images, detailed images. So this leads us that we have a huge amount of radiation in case when we perform the CT scan. So one CT scan, for example, of the brain, it's maybe like from 30 to 5 X-rays, classical X-rays, because we have a huge amount of radiation. So the CT scan is excellent for observing bone and very good for soft tissue, especially with the use of intravenous contrast. For both of this investigation, we can use the contrast, but we should know that the CT scan is extremely well for observing the bone, because the X-ray is good for observing the bone, and also for some special types of soft tissues, like for example, for observing the blood. If you have the hemorrhagic stroke, yeah, it would be extremely well observed on the CT scan. The MRI is excellent for detecting very slight differences in soft tissue. So on the MRI, we can very highly detailed observe the soft tissue. So the cost is not so important, but you should know that the CT scan is usually less expensive than the MRI, and it is much more quicker. Yeah, it takes only about 5 minutes to provide the CT scan of the blood. On the other hand, it takes nearly 45 minutes to provide the CT scan to MRI of the head. So, what are the benefits of the CT scan? It's faster. It can be easily used in the emergency department, and we can very good observe the bones, the hemorrhages, and some general view of some soft tissues. The MRI is usually used to provide much more detailed images because it's more expensive, it takes more time, and it is not usually used in the emergency department. And also we have some risk because it can be harmful for pregnancy, yeah, for babies. So because it has a dose of radiation. So next we are moving to different types of brain dislocation syndromes. So what are the brain dislocation syndromes? As you can see here, we have the MRI. Some processes is happening inside of the brain. Yeah, here we have the edema that is covering the this tumor maybe, and we can see that we have the removing of the neural structure. First of all, we should see the lateral ventricle here, one lateral ventricle, and the second lateral ventricle is not observed. Yeah, it is absolutely compressed. Maybe here some part from, and as you can see, the soft tissue is removed. And this soft neural tissue removing, yeah, or dislocation is called the brain dislocation syndrome, the brain herniation. Why is it important to know about the brain herniation? So first of all, because it's the life-threatening condition. If some nervous tissue is compressed, yeah, the patient can die, or he can have some life-threatening situation, and we need to do something to save his life. So it is a classical image of the brain dislocation. First of all, it can be the subfalcine dislocation. We have the singular gyrus here. It's the lowest part that is nearly the corpus callosum. And if something, for example, is happening here, like this hematoma, yeah, the brain tissue will dislocate and the lateral ventricle will be compressed. As you can see here, we have asymmetry of the ventricles, and also the part of the brain tissue will be moved under the tentorium, because as you know, under the falx, I'm sorry, under the falx, because as you know, previously we were talking that we have the procedure of the Dura Mater that is called the falx, and the falx is dividing two hemispheres. Next, we have the transdentorial herniation. Transdentorial herniation, when, so after this nervous tissue has dislocated, yeah, the volume of the skull is constant. It cannot be increased because we have the constant volume inside. But the brain tissue itself is is really plastic, yeah, and it can be easily dislocated. So next we have the transdentorial herniation. the under the tentorium. As you remember, the tentorium is covering the cerebellum, and it is dividing the brain hemispheres from the cerebellum. The lowest part of the brain tissue is the uncus, the uncal gyrus. It's the part of the temporal lobe, and this uncal gyrus can be dislocated under the tentorium. So this is the transdentorial herniation, and we will have some special clinic in this case. Next, we are talking about the posterior fossa herniation. If the same hematoma or maybe the same tumor should take place in the posterior part under the tentorium, the brain tissue has two exits. Yeah, it can move upward, yeah, the cerebral transdentorial herniation, or it can move downward, yeah, the cerebral tonsillar herniation. And also, if you have some fractures of the brain, yeah, it can be transscapularis herniation. As you can see here, different types of this herniation, subfalcine herniation, yeah, subfalcine herniation, yeah, can cause the dilation of the contralateral ventricle, due to the compression of the contralateral foramen Monro. So here the foramen is compressed, the cerebrospinal fluid cannot be evacuated, yeah, and we have the improving the size of the ventricle. Next, if we have the transdentorial descending brain herniation. So this is the displacement, rotation, and elongation of the brainstem. Yeah, if you have the anterior or posterior, it will cause the widening of the contralateral ventricle and the temporal horn. And also we have the tonsillar herniation. The cerebral tonsils are dislocated throughout the foramen magnum. Yeah, this is the foramen magnum herniation. The cerebellar tonsil will dislocate into the foramen magnum. What is the same for all these types of brain herniation? So first of all, the condition of the patient is worsening throughout the minutes. If you have some hematoma that's increasing its volume inside of the head, it will compress the brain structure, and the patient is going to become worse. He will slowly decrease the level of his consciousness. If he was absolutely alert, yeah, he can become he can have some dizziness and so on. So that was the basic neuroanatomy. Now we are moving to the traumatic brain injury. So first we start from the definition of the brain injury. The head injury is defined as any trauma to the head as a superficial injury of the face. This is the definition from NICE 2017. So we have the trauma of the head as a superficial injury of the face. And also traumatic brain injury is a non-specific term describing blunt, penetration, or blast injuries to the brain. Traumatic brain injury can be classified as mild, moderate, or severe, typically based on the Glasgow Coma Scale. We will talk about Glasgow Coma Scale a little bit later. So, what is going on here? We have different types, yeah, different type of the injury. It can be blunt, it can be penetration, and it can lead us to the different state of patient. Yeah, the patient can worsen or can be in severe situation. If we are talking about the classification of traumatic brain injury, So we use this anatomical classification. So first of all, the traumatic brain injury can be closed or it can be opened. We should call the trauma opened if we have the injury of the aponeurosis. So if the aponeurosis is not injured, yeah, if there is a wound that is not the wound of the skin with the no injury of the aponeurosis, we call this trauma closed. But as well as we just get the aponeurosis injury, if we have, for example, some wound and we observe the aponeurosis, in that moment we can call this trauma opened. Why is it important? Because if the trauma is opened, yeah, we can have some possible connection between the atmosphere and the inner part of the skull, and this can lead us to the thought. This can lead us to some idea that we have some possible secondary meningitis or some secondary encephalitis, because some bacteria or some viruses can migrate inside of the brain. So if the trauma is opened, we can also classify this non-penetrating, when we have non-penetrating trauma, and the penetrating trauma. To call the trauma penetrating, yeah, we should have the injury of the Dura Mater. So if you have the brain injury, and you can see that the Dura Mater is injured, yeah, you can classify this trauma as penetrating. So next we have this classification. It's the clinical classification for different types of the traumatic brain injury. First of all, we have a diffuse process. What does mean the diffuse process? So if the injury of the brain, or if some process inside of the brain is diffuse, it means that it's happening in every part of the brain. Yeah, it can be the swollen edema. Yeah, it can be some other, for example, the hydrocephalus. It happens inside in every part of the brain. On the other hand, if something is focal, it means that it's localized in some special part of the brain. So diffuse traumatic brain injury include the brain concussion. We will talk about the brain concussion next. It also a diffuse axonal injury. It's the rare condition, but it has his special clinic. And also this blast or shaken baby syndrome is much more common, not much, it's common in the pediatric practice. So what about the focal traumatic brain injury? First of all, we have the contusion. The difference between the concussion and the contusion is that in case of contusion, we can observe some special disorder inside of the brain tissue. It can be the hemorrhage, it can be some local penetrative trauma and so on. But in case of concussion, on the neurovisualization, we will observe no changes. Next, we have the hematoma. The hematoma is collecting of the blood in some special area. It can be the epidural hematoma, subarachnoid hemorrhage, and subdural hematoma. Or it can be the intraventricular traumatic hemorrhage. So when we have the trauma and the collection of the blood inside of the ventricle. Or it can be intraparenchymal or intracerebral type of the hemorrhage, when the blood is collecting inside of the brain tissue itself. Usually the hemorrhage starts from the intraparenchymal, and then if the volume of blood is high, the blood moves to the ventricle. Okay, that's it. Let's move to the special conditions. As I told you previously, we have the different criteria for the brain injury. It can be mild, it can be moderate, and it can be severe. This is important for the prognosis and also for some clinical diagnosis. What are the main factors that can impact this classification? First of all, is the Glasgow Coma Scale. So the Glasgow Coma Scale is a clinical scale used to reliably measure a person's level of consciousness. after a brain injury. First, it is used for measuring the level of consciousness. Second, it was produced for the post-traumatic measurement. It is not very good for measuring the level of consciousness in the patient with stroke, for example. It's very good for using the traumatic patient level of consciousness. The Glasgow Coma Scale assesses a person based on the ability to perform eye movement, verbal response, and the movement of their body. The maximum scale is 15, and the lowest is the 3-point. If you have no response, and no response. It means usually that the patient is dying. So these 3 behaviors make up to 3 elements of the scale: eye movement, verbal response, and motor response. Maximum is 15 points, and the lowest is the 3 points. So if the patient has from 13 to 15 points throughout the Glasgow Coma Scale, usually it's the mild traumatic brain injury. If from 9 to 12 is the moderate, and lower than 8 is the severe situation. Next, we have the loss of consciousness. The patient by itself cannot represent the exact amount of times that he was unconscious, so we should ask someone who was with this patient. Also, some post-traumatic amnesia. Yeah, the patient can lose his ability of memorization. And also the alteration of consciousness or mental state after he was awake. Yeah, how long he was unconscious in the hospital. So the first clinical condition that we would like to tell today is the brain concussion. A concussion is the brain injury associated with the rapid brain movement and characteristic clinical symptoms, with no associated objective biomarkers or pathological brain changes, thereby making it difficult to diagnose by neuroimaging or other objective diagnostic tests. So, the brain concussion is the clinical diagnosis when the patient, after, for example, fall or after some rapid brain movement, yeah, it means that, for example, he was hurted or something like that, he has some clinical condition. Yeah, he has some complaints, he has some neurological symptoms, but when we performing some neurovisualization for this patient, even if you are performing the MRI, yeah, we will see no changes. Nothing on the macroscopical level is going on with his brain. But what is going on? The changes are happening on the microscopic level. Yeah. First of all, we have some problems with the ionic flux. Yeah. The ions inside of the cells, we have the disorders in their movement that can cause some headaches, photophobia or phonophobia. So next we have some synaptic injury. Yeah, the synaptic transition is injured that can cause some slow processing, slow reaction time. The patient can have some, he will be answering for your question with some pause. Next, we have some small inflammation. Yeah, it's not a huge inflammation as we represented in our head, but we have some microscopic neuroinflammation, and it can lead us to long-term neurodegeneration. There are some investigations that show that the patient that with brain concussion in their life has much more higher risk of some neurodegenerative disorders. So, the physical examination is extremely important in this patient. Why? Because we need to provide the diagnosis. So we need to perform the close examination of the head and neck area for some structural injuries. It can be wounds, it can be some hematomas. Next, we should perform the precise neurological examination that will include assessment of strength, sensation, and reflexes, ocular movement, including saccades that are fast eye movement, nystagmus, the shaking of the eye, and assessment of patient's balance and vestibular system. We can check the balance with the Romberg position, and the vestibular system can be checked for some ataxia with face, finger, nose, finger test, or finger hammer test, and so on. Also, we need to assess the cognitive function that includes orientation and some cognitive processing. We should ask patients some, for example, some mathematics, if he can provide some cognitive processing, if his cognition is okay. And also we should check the emotional state. That includes a comparison of patient's current emotional state to their baseline with their family or friends. So the concussion still remains exclusively clinical diagnosis that is based on history and exam findings. Imaging should be normal and just help us to rule out if there are no other injuries that can mimic the things and the symptoms of the concussion. After diagnosing the concussion, the patient can be on the observation inside of the hospital if he has some complaints, or he can be on the observation of his neurologist. The treatment of the concussion is primarily supportive. So next we are moving to the precise head injury. So the concussion is the special type of head injury because we have no macroscopical changes. And here we have the other types of injuries that will bring us some special changes on the neuroimaging. We have the contusion, we have the subdural hematoma, epidural hematoma, traumatic subarachnoid hemorrhage, fractures, and the scalp laceration. The contusion of the brain. If the bruising to the brain suffers, usually caused by the trauma or brain being thrown through, being thrown around inside the skull, usually accompanied by the cerebral edema. The contusion size and edema can increase after the injury that can provide some secondary complication. The risk of the swelling is in third, fourth, and the fifth days after the injury. And usually this patient can have a higher risk of the seizure activity. So we have the primary injury, for example, focal brain contusion, vascular and blood-brain barrier rupture. We can have the hemorrhage in different parts of the head. We will have the injury of the neurons. We have some problems with the neuro communication. We will have the increased synthesis of the cytokines, chemokines, and the association of the neurometabolization. That will lead us to the secondary injury. So this inflammation, oxidative stress, excitotoxicity, cell death is happening in the next days after the injury. So on the day 2 or day 3, we will have a lot of neurons die, and other neurons can have the demyelinization or neurodegeneration because, first of all, of the swelling edema, and secondary because of the problems with the molecular patterns. Because we have the inflammation, we have some other processing happening inside of the brain. And then the neurological deficits that is coming throughout the brain injury, we will have the loss of the neurological function, the cognitive problems, the psychological alteration, and chronic disability. Here you can see the classical brain contusion. It's the CT scan of the brain. As you can see, this is the normal brain tissue, and here you can observe some amount of blood. On the CT scan, the blood is white because it consists some ferrum, some iron ions, and in this area we have the brain contusion. This is the same brain contusion. Here we have, as you can see, it's the dark area bilateral, and here we have some amount of blood that is localized inside of the brain tissue. So another representative of the brain contusion, as you can see, it's the collection after the trauma. It's like the collection of the blood inside of the brain. Here we have some hematoma. The difference between this, it's not the hemorrhage, but it's like the blunt trauma result. And here we have the hematoma, and the hematoma, brain dislocation. We were talking about it previously. Yeah, as you can see, we have the compression of the lateral ventricle, the dislocation of the ventricle, and the collecting of the blood. So this is the special type of neuroimaging that is called PET, and it can show us different neurological pathways and the connection between the neurons inside of the head. How should we treat the patient with the contusion? So the most common and the most widely provided operation is the surgical decompression of the head. If we have the accommodation of the blood, yeah, the volume of the blood of the hemorrhage is increasing. We have the brain dislocation. Yeah, we should evacuate this blood from the head, from the skull. So we provide the incision of the scalp. We provide some multiple holes inside of the skull, and then we are just removing the hematoma. We evacuate the hematoma and placing this bone back to the skull and making some clips. Yeah. And this is how the decompression, surgical decompression is provided. But we have a lot of complications after the decompressive craniectomy. As you can see here, it can be the external herniation. As you remember from our previous slide, the brain tissue can dislocate outside of the skull. Also it can happen some dilated hematoma, hydrocephalus, or intracranial infection. Usually it's not highly risk because we prescribe some antibiotics for this patient. And here you can see we have no, so it is the skull, this white layer is the skull, and we see no bone here because unilateral decompression. This part of the temporal bone was removed. Next, we are moving to the subdural hemorrhage. So the subdural hemorrhage is the gathering of the blood between the inner layer of the Dura Mater and the Arachnoid Mater, usually resulting from tears in the bridged veins which cross the subdural space. So the main source of the bleeding is the venous blood, the venous bleeding. Subdural hemorrhage may cause an increased and intracranial pressure, which can cause compression and damage of the brain tissue. What should we know about the subdural hemorrhage? First of all, it's the venous bleeding, and the amount of blood is not usually is not collected extremely quickly. We have slow progression of the hematoma. Even in clinical practice, we can even observe some chronic subdural hematoma. Some patients, especially elderly patients, can have the chronic rupture of the vein, and the blood will be connected so slow that this process will happen for 2 or 3 weeks. Next, the shape of the hematoma, as you can see here, It's like the moon shape. And the area and the amount of blood that can be accumulated here is much more higher if we will talk about, if we will compare it to the epidural hemorrhage. So these two factors will be important for us when we will be comparing these two types of hematoma. What should we perform? We have the treatment of traumatic acute posterior fossa subdural hematoma, the report in the clinical guidelines. Yeah, so it's easy. If the thickness, we measure the thickness on the CT scan, is more than 10 millimeters, and the patient Glasgow coma scale is less than 8, we should provide the craniectomy. We should provide the surgery and to remove the hematoma. If the patient has the thickness of the blood is lower than 10 millimeters, and the patient has no signals of mass effect, here we have the dislocation, but sometimes it happens that we have no symptoms of dislocation, the volume of the ventricle is normal, we can observe this patient. We can provide some medical treatment and can repeat the CT scan in 6 hours and observe this patient, what is going on. So it leads us to the conclusion that if the amount and volume of the blood is high and we have the worsening of the state, we should provide the craniectomy. Next, we are talking about the epidural hemorrhage. So epidural hematoma is the collection of the blood between the inner surface of the skull, and the outer layer of the Dura Mater, between the skull and the Dura Mater. Epidural hematoma is the life-threatening condition which may require immediate reaction and can be associated with the high level of mortality. Why? We will talk about it a little bit earlier. So usually the source of bleeding is the artery rupture. We have the middle meningeal artery that is usually ruptured when we have the skull temporal bone fracture, and this patient can have the epidural hematoma that the as well as the source of bleeding is arterial, the worsening of the patient will happen very quickly. So epidural hematomas are typically biconvex in shape. So here we have the crescent shape, and here we have the biconvex lens shape. So usually this shape is the result of the tight junction between the Dura Mater and the places where the skull bones are connected to each other. So as you know, we have different skull bones, here the frontal bone, the temporal bone, the occipital lobe, and in the places where these bones are connected, we have a tight junction between the Dura Mater and these places. So the amount of blood and the place for the blood accumulation is constant. It usually is not moving throughout the area of one bone. Usually it's the temporal bone. Here we have some emphasizing, some comparison of epidural and subdural hematoma. First of all, the epidural hematoma is between the skull and the outer layer of the Dura Mater, and the subdural is between the dura and the arachnoid mater. So this blood is arterial blood, and usually the subdural is the venous bleeding. The main source, the main vessel that produces the epidural hemorrhage hematoma is the middle meningeal artery, and the bridging veins are the main source of the subdural hematoma. The symptoms of the epidural hematoma are usually connected with lucid interval. So the lucid interval, it's the interval of time between the fact of trauma, when the blood starts its collecting inside of the skull, and the time when the symptoms or patient's worsening has begun. So, for example, the patient can got his trauma 3 hours ago. The hematoma is already collection inside of his head, but still he can have no symptoms. Yeah, maybe if the trauma was not so huge, maybe he hurt his head, for example, the collection of the blood will take some time, few hours, for example, and this time before he will come to the hospital with the worsening of his condition or decreased level of consciousness is called the lucid interval. And here are the classical representing: epidural hemorrhage, epidural hematoma by convex shape, and the subdural hematoma, subdural, crest lens shape. Here we have one more comparison, subdural epidural hematoma, and also we need to talk a little bit about the subarachnoid hemorrhage. So we will talk much more about the subarachnoid hemorrhage when we will have our stroke lecture, but you should also, so in population, the main reason of subarachnoid hemorrhage is the rupture of the aneurysm. But in some patients, it can be the traumatic subarachnoid hemorrhage, the subarachnoid hemorrhage after the trauma. So the subarachnoid hemorrhage is the collection of the blood in the subarachnoid space. That means that the blood will diffusely represent in between the gyrus, between the ventricles. It will completely and diffusely localize inside of the head. And also we can have some intraparenchymal hemorrhage, when we have the rupture of the vessel after the trauma and the blood accumulates inside of the brain tissue. So that was the overview of the traumatic brain injury. Our second part of our lecture is the spinal cord injury. I would ask you to connect to this link one more time, because we have the finishing of this part of the lecture, and we will continue after you will reconnect in a few moments.